Good morning and welcome everyone to this first webinar in the 2019 Meerkat webinar series, and thanks for joining us. My name is Phil Cohen and I'll be the moderator for today's session. For those of you who don't know me, I'm a social researcher by training and have had more than 25 years of experience in both the government and non-government sectors. I've extensive experience with quality in the healthcare sector and have been involved with the BPCLE initiative almost as long as our webinar presenter, who is my colleague, Donna Cohen. Most of you probably already know Donna, at least by sight, if you've watched any of the video tutorials in the BPCLEtool. Donna has been a major contributor to initiatives aimed at improving and expanding the clinical education and training capacity of Victorian health services. She's also developed an extensive practice in quality improvement, evaluation and strategic planning, particularly in the public and not-for-profit sectors. So today's presentation is going to review data from the rollout of a quality improvement initiative in clinical education and training that's been in place in Victoria since late 2013. The initiative, known as the Best Practice Clinical Learning Environment, or BPCLE framework, actually started back in mid-2008. So it's been going for over a decade.
Yeah.
And judging by the list of people registered today, I imagine most of you know about the framework and may well be involved in submitting indicator data to the Department of Health and Human Services each year using the BPCLE tool for that. So Donna, can I ask you briefly to recall what happened in the years between 2008 and 2013? When the framework was first rolled out in Victoria?
Yeah, certainly. Well, thanks, Phil. And hello, everyone. And thank you very much for joining us today. So the early years were spent developing the framework itself and the associated resources. The first project that we worked on was where we actually developed the framework. And that actually started with some research to see what was already out there in the field.
And did you find anything?
Well, actually not really. There were a couple of discipline-specific frameworks in nursing and occupational therapy, but there was really nothing along the lines of what the then Department of Human Services was looking for. What they wanted was a framework that would apply to all health professions and all settings in which clinical education and training activities take place. So what we started doing was some consultations with university clinical education coordinators, with hospital clinical educators and education coordinators, and of course, learners at both the undergraduate and early graduate levels. And we did that to find out what their views were on the essential elements or underpinnings of a high quality clinical learning environment. So for the first project, we only worked with the hospital sector, and also we only worked with the largest 7 disciplines in terms of the numbers of undergraduate student placements, and that included medicine, RN nursing, OT, physio, podiatry, social work, and speech pathology. So then the second project, which was in 2009, was a validation project. And this is where we took the framework that we had developed out back to stakeholders to see what they thought of it. And during this project, now we also included all health professional disciplines and all service settings in which student placements are undertaken.
And did that result in many changes to the framework?
Well, actually, strangely enough, no. We thought it might do, but there were some issues around language usage. But the 6 elements themselves of the framework, those were validated by all stakeholders, and the core content was signed off as being appropriate.
Mm-hmm. So a great foundation was set with that work. And then what happened after 2010, I think?
Yeah, that's right. So in 2010, we conducted 2 projects. The first was to develop a performance monitoring framework, which is basically the 55 BPCLE indicators. And those are the indicators that are now used by Victorian Health Services when they report and monitor and report on the health of their clinical learning environments. The second project was to develop what's called the BPCLE resource kit. Then in 2011, the department wanted to conduct an implementation pilot, and so we went out to 11 health services across the state to trial the approach that we had developed. And those 11 health services included metro health services, some regional and rural health services. Also, we had one aged care provider, community health provider, and also GP clinics.
I remember I was involved with 5 of the sites. And generally the pilot worked well, as I recall, but there was a bit of an issue with the Excel format that we had in terms of the tool.
The approach that we had developed was appropriate and feasible for all the different settings that we went to. And the people that participated really liked the approach and the tools that we developed, although, as Phil just alluded to, having said that, the prototype tools were developed in Microsoft Excel. And stakeholders told us that if we were really serious about rolling this out across the state, then we probably should come up with an online version of the tool. And that's what we did in 2012-13. And that tool is what everyone now knows as BPCLEtool. So that was rolled out to Victorian Public Health Services in late 2013, and then to registered community health services in 2015.
Great. So that gives us a bit of a brief history of the extensive development. I mean, if people have questions about that, they can always address that offline later. But now I think you get to with the focus of today's presentation, which is the data that we've actually seen over the last period, over the last 5-6 years now.
Yeah.
So I'll hand over to you, Don. I'm going to move to the side and just monitor. So if people have queries or anything, I'll be keeping track of that.
Fantastic.
And coming later for the questions.
Very
over
good.
to you, Don.
Thanks, Phil. Okay, so I'll just get myself set up here. I'm ready to go. Okay. So now, before I show the data analysis that we've undertaken, I want to briefly review the steps that lead to data being collected in BPCLEtool. Now, this is probably not going to be news to those of you who are very familiar with using BPCLEtool, but it will help to contextualize the data analysis for a number of people who are joining this webinar today who are new to BPCLE framework and BPCLEtool. So implementing the BPCLE framework in a health or human services organization involves 3 major steps. The first step is to apply the guidance that's presented in the framework to the clinical education and training arrangements that are already in place within the organization. And this is accomplished by firstly assessing your current arrangements against the framework, and secondly using the outcomes of that assessment as the basis for development of a quality improvement action plan. The second step then is to implement that action plan, and the third step is to collect, analyze and report data against the indicators. And it's worth noting that organizations are not expected to monitor all 55 of the indicators, thank goodness. And indeed, just as the outcomes of the assessment are the basis for deciding what to include in your quality improvement action plan, the assessment outcomes are used by BPCLEtool to suggest which of those 55 indicators would be the most appropriate ones for your organization to monitor. Anyway, the main point that I want to leave you with here is that what we call assessment data is derived from this step of the process, while indicator data is, of course, derived from this step of the process. Now, for those of you who are very familiar with quality improvement activities, you will probably recognize those 3 major steps of framework implementation as a plan, do, review, quality improvement cycle. The plan step, of course, encompasses these activities of self-assessment and action plan development. The do step is where you implement your action plan, and the review step then, of course, are all the various activities associated with indicator monitoring. Now, in recent times, when I've been speaking to health service personnel who have questions about using BPCLEtool, I've gotten the feeling sometimes that the emphasis has become on the review step. But it's really important to remember that the framework was developed to provide guidance for continuous quality improvement. And so there is a lot more to implementing the BPCLE framework than reporting in data against indicators once a year. And indeed, the analysis that I'm going to show you today comes from the assessment data that was collected in BPCLEtool. And I'm not actually going to show you any analysis of indicator data. And the main reason for that is because the indicator data entry forms in BPCLEtool were changed very substantially in 2016. And so we only now have 3 years of continuous indicator data to analyze and to monitor trends. And so we hope to get underway with that analysis soon. So let's take a look at the assessment process to see where the data actually comes from. Now, in case you don't know, if you're new to this, the BPCLE framework comprises 6 elements that are the essential underpinnings of a high-quality clinical learning environment. And each element encompasses a number of objectives. So, for example, you can see here that element 1 has 6 objectives, element 2 has 3 objectives, and so on. And I'll just draw your attention to element 4 down here in green, which you can see has 4 objectives. And I'm going to talk about element 4 in just a moment. Now, when we were developing the BPCLE framework, we developed logic maps or logic models for each framework element, and I'm going to show you one on this next slide. Now, the logic map shows, in general terms, the inputs, the processes, and the outputs and outcomes through which, or which need to be in place in order for the objectives of each element to be achieved. And this logic map is for element 4, which, as I mentioned a moment ago, has 4 objectives. And you can see that those are the 4 purple diamonds here at the bottom of the map. Now, in BPCLEtool, the logic maps are presented as interactive tools that allow organizations to rate how well each of these map items, which are called nodes, N-O-D-E, node, how well each node is currently being achieved. So the general idea is that you conduct your assessment as a team exercise so that you get input from all the people in your organization that are involved in the various aspects of organization, management, and delivery of clinical education and training. Assessment sessions thereby become a sort of interprofessional learning and ideas sharing exercise, whereby staff contribute to the rating of each node based on their own knowledge and experience, which is why the assessment step is referred to as Map-Enabled Experiential Review, or MEER. And you can see here what the map looks like after all the nodes in it have been rated. And at the bottom, on the lower right-hand corner here, you can see in generic terms what the rating scales look like. So you can see that they are essentially a 5-point Likert scale. Then you have 2 additional rating options, a does not exist option and also a not applicable option. The rating scale for each node is actually unique to that node, but in essence, it is a 5-point Likert scale with 2 extra rating options. So if an organization rates a node with a rating equivalent to either a 5 or a 4, in other words, above average, then the node gets a green tick in the map. If the node is rated with an average score or a below average score, in other words, equivalent to a 3, 2, or 1, then it gets a red halo with an exclamation mark. If it's rated as does not exist, in other words, a score of 0, then it gets a black halo with a cross. And if the node is rated as not applicable, it gets grayed out in the map. Now, from a user perspective, you can see that when the assessment is completed for each element, you get an instant snapshot of where things are going well and where issues exist that need to be addressed. From a data analysis perspective, the BPCLEtool database collects node rating scores for every assessment that's been conducted. And since there are 239 nodes across the 6 elements, the record for each completed assessment includes 239 node ratings. And we're able to extract de-identified records from the database to analyze how health services across the jurisdiction have rated their own clinical education and training arrangements. So I mentioned earlier that BPCLEtool was first rolled out in Victoria in late 2013. And over a 5-month period to about mid-April 2014, there were 102 organizations that completed an initial assessment using BPCLEtool. In early 2018, we downloaded data from all those assessment records, and for each of the 239 nodes, we then calculated the proportion of those 102 organizations that rated the node as above average, which will be shown on the following slides with a green bar, average or below average, which will be with a red bar, does not exist, which is with a black bar, or not applicable, which will have a gray bar. So on this next slide, I'm going to show you aggregated data from the 102 organizational assessments. And in this first instance, I'm only showing you the data for element 1. Now, this is a percentage stacked column graph. So for each node, there is one column, and there are 41 nodes in element 1, so there are 41 columns here. And what I've done is to arrange the nodes in order from left to right so that the node at the left-hand end shows you the one where the highest proportion of those 102 organizations rated it above average. And then the node at the right-hand end is the one where the lowest proportion of those organizations rated it above average. And the black line you can see at the 50% level, of course, signifies the median rating level across the 102 organizations. So from the left-hand side up to about this node, this is where more than 50% of the health services rated the node above average, as you can see by the length of the green bar. And you can see that there is a considerable range in how well Victorian Health Services perceived their achievement of these various aspects of element 1. And now here are the results for the other BPCLE elements. And by comparing the results between the elements, we can see that element 2 had the highest proportion of nodes rated above average by the majority of health services, while element 6 down here had the lowest proportion of nodes rated above average by the majority of health services. So the take-home message from this baseline analysis, there were several. The first was that there was in fact quite a lot of variation across Victorian health services in terms of how they rated their achievement of the different aspects of high quality clinical learning environments. And of course, that's probably not particularly surprising. And the second take-home message was that element 2 was rated best across Victorian health services, while element 6 was rated worst. Now, what I want to do is to take a look at just one of the elements to show you some of the other information that we were able to glean from this analysis. And so I'm going to use element 6 because it only has 12 nodes. So this is the same data that I showed you on the previous slide, except that here, the nodes are presented in their order across the map. So we've got node number 1 on the left-hand end and node number 12 on the right-hand end. So they're sorted in map order instead of their order from highest to lowest in terms of how well they were rated. And here again is the 50% line showing the median score. And you can see that when we're looking at all of the data from all of those 102 organizations together, only 2 of the nodes, here and here, were rated above average by at least 50% of the organizations. Now, since the organizations that completed these assessments were tagged with one of the 7 Victorian clinical training networks, we were able to disaggregate this data to see whether there were any differences between the networks. In other words, between the various regional and metropolitan areas of the state. And that's shown on this next slide. So each of these bar graphs shows the aggregated data for organizations within a particular network. So the 102 organizations are now split across these 7 graphs. And the graphs are presented in order such that this network here is the one that had the best results to here, which is the region that had the least good results. So in the best network, taking account of not applicable ratings, almost all of the 12 nodes in element 6 were rated above average by the majority of health services in the network, whereas in the least good network, only 2 of the 12 nodes were actually rated above average by the majority of health services in that network. Now, it's worth bearing in mind that this element, element 6, is for appropriate resources and facilities. And one might assume that the metropolitan health services would rate better for this element of the framework than would regional and rural health services. But actually, you can see that this was not the case. The networks where the health services rated their resources and facilities the best were actually in regional Victoria. So the key point that I want you to take out of this is that the assessment ratings were not uniform across the state or within network types, and they were also not uniform across setting categories and didn't necessarily conform to any of the preconceived ideas that we may have had about where health services are likely to be found. So the data that I've shown so far has all been from the baseline assessments that were conducted early in 2014. And while that gives us a really good snapshot of how things were when the framework was first rolled out, it doesn't really tell us what impact, if any at all, the framework implementation has had on the quality of clinical learning environments since it was first implemented. Now, the department did encourage health services to conduct follow-up assessments in keeping with a plan, do, review, quality improvement cycle. And by early 2018, when we started to analyze the data, roughly half of all organizations had completed a second assessment, and indeed, in some cases, they'd even completed a third assessment. However, for some of the organizations that completed 2 assessments by early 2018, the disciplines that took part in the second assessment were not the same as those that completed the first assessment. And this was important because we wanted to be able to directly compare the 2 assessments as well as possible. But fortunately, there were 45 organizations where the 2 assessments could be paired. And this next slide shows you the distribution of organizations in terms of how much time elapsed between the first and second assessments for those organizations. So you can see that roughly 20% of second assessments were conducted within 2 years of the first assessment, and about 60% were conducted in the 2 to 3 year period after the first assessment. Now, this next slide is going to present the data from those paired assessments a little bit differently than what I was showing you earlier, because now you're going to be looking at the difference between the node ratings in the second assessment compared to the first. Now, once again, the chart I'm showing you here is just for element 1 in the first instance. And what you're looking at are the proportion of element 1 nodes where the second rating was either, in the case of this gray bar, the same as in the first assessment. So this is the gray bar at 0. So the rating difference is 0. They were the same in first and second assessments. And then you can also see the proportions of nodes where the second rating was 1, 2, 3, 4, or indeed even 5 ratings higher than it was in the first assessment. And those are shown in aqua. Or the nodes that are rated with the purple bars are the ones that were 1, 2, 3, 4, or 5 ratings lower in the second assessment than in the first one. So regardless of what the rating was the first time around, what we were asking was, did the rating stay the same? That's the gray bar. Did it increase? These are the aqua bars. Did it decrease? The purple bars. And if so, by how much? So what you can see from this graph is that about 35% of the node ratings of element 1 did not change. They stayed the same between the 2 ratings. About 45% of the node ratings increased, and about 20% of the node ratings decreased. And you'll see here that the story was fairly similar with the other BPCLE elements, although you can also see that the proportions that stayed the same or that increased did vary a little bit from element to element. So this was the data from the whole pool of 45 organizations where we had paired assessments. I'm going to show you similar data, but now disaggregated by setting type. So on this first line, you can see the data that we collected from community health services, and you're looking here at the 6 elements going across the line. So this is element 1, element 2, 3, 4, 5, and 6. And what you can see immediately from looking at this is that we found more variability between the 6 elements in terms of how the node ratings changed than we saw when we looked at all of the organizations lumped in together. So, for example, you can see here in element 2 that about 60% of the node ratings didn't change in the second assessment, and out here for element 6, you can see that about 45% of node ratings didn't change, but when they did change, they only improved. And here's what we find for the other 3 setting categories. So you can see that we have a category for metro health services, regional health services, and rural health services. And you can see the sort of patterns by looking at across the 6 elements for each of those different categories. And when you look at that, immediately what strikes me is that I actually saw a bit more similarity in the pattern between the metro and the rural health services than I did with either the regional or the community health services, which had slightly more distinctive patterns. So the key point to take out of this is that the changes that were recorded in the node ratings between the first and the second assessments were not uniform across setting categories. They didn't necessarily conform to our expectations and included some nodes where the rating improved between the first and second assessment and other nodes where the rating went down in the second assessment. Now, this last point is actually particularly important, because it tells us that the people that took part in the assessments were not just gaming the system. In other words, they weren't just giving a higher rating the second time around because now they knew how the system worked and they just wanted to make their arrangements look better. Instead, they were genuinely and honestly trying to rate the various aspects of their clinical learning environment based on their own experience. And about 45% of the time, this resulted in an improved rating in the second assessment, and about 20% of the time, this resulted in a lower rating. So now I want to delve into these rating changes in a little bit more detail, because we can actually see some very important outcomes by looking in a bit more depth. So this next slide is going to show rating differences. I'm only showing up in the top corner for the moment just to explain the graph to you. Again, this is showing rating differences, but this time we've disaggregated the data by the score that was recorded in the first assessment. Okay, so in this graph shown here, we're looking only at element 1, and we're looking only at those nodes within element 1 that were rated does not exist, a 0 rating in the first assessment. And what you're seeing with this graph is the difference between the first and the second rating. So what you can see is that for about 12% of these nodes, they were rated does not exist in the first assessment, and they were still does not exist in the second assessment. But what you can see also is that for nearly 90% of the nodes that were rated does not exist in the first assessment, they improved in the second assessment, and the improvements were not small. You can see that about 70% of the nodes in the second assessment were rated 3, 4, or 5 rating points higher, which takes them to an average rating or an above average rating. And indeed, you can see that the mean rating difference was 2.9. So this means that organizations didn't just implement the missing arrangements, they implemented them pretty well. And this is also very important, because although it could be argued that an improvement in a rating on a Likert scale of responses represents a subjective improvement, a change from does not exist to exists with a rating of X provides objective evidence of improvement in those clinical learning environments. In other words, organizations went from not having some arrangements in place to having those arrangements in place. And of course, that is a significant improvement for those learning environments. So that's what we see for element 1 rating that were rated does not exist in the first assessment. And this is what it looks like for the other rating levels in the first assessment. So we're still in element 1. This is when they were rated 1, 2, 3, 4, or 5 in the first assessment. So if we look first of all at the 1 and 2, in other words, like very poor and poor in the first assessment, again, you can see that in the second assessment, more than 80% of these nodes were now rated either average or above average. And towards the right-hand end of this row of graphs, you can see what happened to those nodes that were rated above average in the first assessment, with a rating of 4 or 5. So when the rating was 4 in the first assessment, about half of the nodes were still rated 4 in the second assessment, about 25% went up to a score of 5, and about 25% were rated lower. When the rating was 5 in the first assessment, of course, there was no higher rating to move to, and indeed only about 35% of the nodes were rated, still rated 5 in the second assessment, and about 65% were rated 1 or 2 points lower on the scale. Now, this doesn't necessarily mean that things got worse, although it might have in some cases. More likely what it means is that going through the assessment process the first time helped staff to think differently about their arrangements. So in fact, they might have been more critical the next time they conducted an assessment. So that's the line of graphs for element 1, and I'm going to show you now the other 5 elements. And I know that's a little bit confronting as a graph, but hopefully you've got the idea of what you're looking at here. And what we could see was that there were differences observable between the elements. So let's first of all just concentrate on this first column of graphs, which of course across the 6 elements where they were rated does not exist in the first assessment. And where we saw the best improvements were in element 2, which was best practice clinical practice, and element 6, which is appropriate resources and facilities. When the rating in the first assessment was very poor, in other words, a rating of 1, the best improvement was seen for element 4, which is an effective health service education provider relationship. And when the rating in the first assessment was poor, in other words, a rating of 2, then the biggest improvement was seen for element 3, a positive learning environment. So that's what we see looking at the nodes from this kind of sort of helicopter perspective. We're also able to look at individual nodes to see what happened to specific aspects of health service arrangements. So this next slide now shows a table listing the 14 worst nodes according to the first assessment. And we judged worst by the ones that had the highest proportion of does not exist or below average ratings. Over here in the left-hand column, you can see the node ID, and that tells you which element the node belongs to. So, for example, this node starts with a 3, and so it was in element 3. So you can see that the 14 worst nodes were the ones that had more than 60% of node ratings were average, below average, I should say, or does not exist. So let's have a look what happened in the second assessment. And you can see from this that there were considerable improvements for almost all of these nodes, not just relative to the rating that they received in the first assessment, but actually also relative to other nodes, because these red asterisks show the nodes that were still among the 14 worst in the second assessment. And you can see that there were only 7 of these nodes which were still in the 14 worst. And you can see that the worst nodes in the second assessment, judging by the level of the ratings, were not nearly as poorly rated as the worst nodes in the first assessment. So the key points from all this analysis here were firstly, that the decrease that we observed between the first and the second assessments in the number of nodes that were rated does not exist, provided us with objective evidence of improvement. Secondly, the nodes that were initially rated below average or does not exist improved not marginally, but substantially between the assessments. And thirdly, we saw some differences between the 6 elements in terms of the level of improvement that was recorded. So now the very last piece of data that I want to show you from our analyses to date is a covariance analysis, where we look to see whether there were changes in ratings for one node and whether those changes correlated with changes in the ratings for other nodes in that same element. I'm going to show you the analysis for element 6 because it only has 12 nodes, and so it's the easiest one to interpret. So this is what's called a heat map, and this shows the correlation between the various nodes of element 6. So we've got nodes 1 through 12 of element 6 listed along the bottom, and 1 through 12 of element 6 listed down the side. And over here is our rating scale, or our key. And with this analysis, a correlation coefficient of 1, which gets this sort of burnt orange color, that is an absolute correlation, while a coefficient of -1, the deep blue color, indicates an absolute inverse correlation. And of course, a correlation coefficient of 0 indicates no correlation whatsoever. So the higher the coefficient, the more likely that a change in one node will coincide with a change in another node. So of course, each node is absolutely correlated with itself, which is this row of ones that runs down the middle of the map. And you'll also realize that the two halves of the map are mirror images of each other. So we're just going to focus on the lower half of this heat map. And what you can see is, just looking at it, you can see that the darkest colors are shown for node 601. And that's because this is the node that had the highest correlations with other nodes in element 1. And I'll point out the 3 nodes where the highest correlations occurred, namely nodes 605, 603, and 611. And now I'm going to show you what this looks like when I map it onto the element 6 assessment map. So here at the top is node 601, and it's an input node, and its budget includes an allocation for providing a suite of resources needed to support clinical education. And here now are the 3 nodes where the highest correlation was found, and the thickness of the arrow shows the strength of the correlation. So we have node 605, 603, and 611. And now I'm going to add in arrows for all the other correlation coefficients in element 6 that were 0.4 or higher. So we've got these 2, this one, these 2, and these 2. Now what this analysis tells us is that there are 3 critical success factors in element 6, namely the budget for resources. Also, building and renovation plans include adequate space and facilities for learners, and mechanisms to ensure adequate access and appropriate availability to learners. Now, this information is useful because it tells us that if you get these 3 things right in your organization, just about everything else in this aspect of your clinical learning environment has a much better likelihood of working out well too. So overall then, the conclusions that we can draw from this BPCLEtool data are, firstly, that there have been improvements in the Victorian clinical learning environments since implementation of the BPCLE framework commenced in early 2014. And these improvements have been demonstrated through significant reductions in the number of nodes rated does not exist, significant improvements in nodes that were rated below average, and although I didn't show this data today, significant improvements in key framework outcomes and objectives. Secondly, we observed differences in the impact of the framework based on both setting type and or the regional location of organizations. So what, if anything, have we gained from the just over 10 years of the BPCLE initiative? Well, firstly, we have a framework for best practice in clinical learning environments that is relevant to all health professional disciplines and all setting types in which clinical education and training activities take place, and which represents a world-leading initiative to drive system-wide improvements in clinical education and training activities. Secondly, in BPCLEtool, we have an online framework implementation tool that assists any health or human service provider to apply continuous quality improvement principles to its education and training activities. And BPCLEtool has specifically been designed to guide organizations through framework implementation without needing any external assistance. Finally, and most importantly, we've seen measurable improvements in the quality of clinical learning environments in the Victorian education and training system. And it would be fair to say that the success in both achieving and measuring those improvements is due in no small part to the existence of BPCLEtool. Because from a system level perspective, BPCLEtool made it possible to have consistent system-wide implementation of the framework. The tool captured significant amounts of baseline data about Victorian clinical learning environments that had never been collected before, and that data provided insights about issues that are region-specific and or setting-specific. Because of the ability to track assessment results over time with node-by-node granularity, This provides a mechanism to monitor the impact of any additional resources or support that's provided to address particular issues. And of course, the covariance analysis will allow us to identify all the critical success factors for establishing and maintaining high-quality clinical learning environments. And then, of course, from an individual health service perspective, BPCLEtool provided them with an all-in-one plan, do, review quality improvement kit. The assessment step allowed organizations to identify where they had issues that need to be addressed and which aspects of the clinical learning environment need to be targeted for improvement. The assessment results also pinpoint which of the 55 BPCLE indicators are most appropriate to monitor. And because of the way the assessment tool is designed, this all-important diagnostic step is very engaging for staff and helps them to develop ownership of quality improvement activities. The BPCLEtool action planning tool, because it is seamlessly integrated with the assessment tool, allows direct transition from issue diagnosis to action planning for improvement. And the Kanban styling of the action plan tool makes it easy to use for ongoing monitoring of action plan implementation. And then finally, BPCLEtool has a range of useful reports for health services to use. And these allow organizations to compare their own assessment results over time, benchmark their assessment results against statewide results, and similarly benchmark their indicator data against statewide results. So look, in drawing my presentation to a close, I'd like to go back to a point that I raised right at the beginning about how the emphasis of the BPCLE initiative seems to have shifted for some health services, although by no means all, to be primarily about indicator monitoring. And I really want to emphasize that quality improvement is not about collecting and reporting data against indicators. That is one part of a quality improvement cycle, but I'd have to say it's not even the most important part. The most important parts of the cycle are periodic review or assessment of your activities, and addressing any issues that you identify through implementation of a quality improvement action plan. Now, look, I know that people who work at the coalface are time poor and have many competing priorities. And I can see how tempting it is to just do the absolute minimum that's required to meet mandated aspects of framework implementation. But I can absolutely guarantee you that simply collecting and reporting indicator data once a year to the department will not result in organizations achieving the quality improvement outcomes that I've shown you today are possible. Those outcomes are only possible when health services embrace quality improvement for their clinical education and training arrangements as an ongoing and continuous cycle of activity. Now, I'm not saying you have to undertake an assessment every 6 months or even necessarily every year, but certainly I would recommend that health services should try to reassess their arrangements every 18 months or 2 years. This will allow you to review the indicators that are most appropriate for you to be monitoring, and will also provide you with up-to-date evidence on which your next quality improvement action plan can be based. So finally, I'd just like to tell you that the success that was achieved with BPCLEtool encouraged us to develop this idea further. And so the BPCLEtool engine can be cloned and adapted for use with different frameworks or different sets of standards. We've also developed a version of the MEER system that can be applied to any program or process, and that's called meerkat. It's also available online. And in meerkat, we've created maps that correspond to the National Safety and Quality Health Service Standards and also the residential aged care and home care common standards, as well as some non-clinical business processes. So we've actually just completed a hospital trial using the NSQHS standard maps in meerkat. And similar to what we found using BPCLEtool to improve clinical learning environments, we found that using this approach was not only very engaging for frontline clinical staff, but it also resulted in significant improvements in the number of adverse events that were recorded. We're just finalizing a paper now on that trial, and I'll keep you posted on when it's likely to be published. Which reminds me that you will find a couple of handouts available to you as webinar participants, including the paper that we published last year on the BPCLE initiative and another paper that we published on the MEER approach to quality improvement. So I will stop there and take any questions that you might have. Phil, come on back.
Thanks, Donna. Thank you very much. I'm just waiting. So again, if you have a question, if you can just raise your hand or actually hit the question button or type the question in, that will be great. So I'll keep a watch on that. But while we're waiting, I mean, one of the things that you talked about were the critical success factors that were identified through the covariance analysis. So how do those critical success factors compare to the indicators for element 6?
Yeah, that's actually a really good question, because it's worth remembering that when we developed the indicators for element 6, well, for all of the BPCLE framework, we were doing it right back at the beginning of the initiative, and it is not uncommon for when you're creating indicators. It's not uncommon at the start of that process to sort of be shooting blind a little bit, because you don't at the start of initiatives know what the critical success factors are for that initiative, and so you sort of have to guess what things are likely to be critical. And you also, of course, have to bear in mind what are the things that can be measured and that you can get meaningful data out of. So when we developed the indicators for element 6, there were 4 indicators that were specific for element 6 and 1 indicator that shared with element 1. And the 4 indicators that are specific for element 6 do not align to these critical success factors. The only one that does is indicator 13. But even there, that's an outcome indicator. It's not an input or a structural or a process indicator. And so it's, at best, it's an indicator that is aligned to the critical success factors, but it's not going to tell you whether you actually have those things in place, except really only indirectly. So it's possible that we need to see if we can come up with some different indicators to go to those critical success factors. But I have to tell you, I gave some thought to this after we did that analysis. And it is not obvious to me how you can have an indicator to measure whether a mechanism is in place or not, or whether the other things that were in there about I forget exactly which nodes they were, but it was not actually apparent to me how you can come up with those indicators. And in fact, the best way to determine whether those arrangements are in place is to do an assessment and to talk with your colleagues about whether the budget is adequate, whether the mechanisms are in place, and whether, oh, that's right, the third one was whether or not the resources and facilities have been prioritized for educational use. Do the assessment is probably the best way to work out what's going on.
Thanks. I know we've had a couple of people raise just the issue about will the slides from this presentation and will the presentation itself be available. So yes, we will be making that available, both the slides and the presentation. So is that a handout or?
No, the presentation is not a handout, but we can certainly, I'll make a PDF of the slides and I will provide that to you. The handouts are available now, and we are recording this now. So you will be able to watch a video or share that with your colleagues afterwards.
Great. We've had someone just asking about, is it possible, I think this is from one of our overseas attendees, can you use the framework without having to have the whole a whole government approach or someone or the health department implementing it?
Yeah, absolutely. So individual health services they're very welcome to, or like if there was a network that wanted to implement this, or maybe, for example, if there was a private hospital group that wanted to implement this framework, you don't need to have jurisdiction oversight of this. You can just do this within your own organization. Yeah, absolutely.
All right. I'm just looking through. There's another one here. Do you have to complete assessments for all 6 elements to get the benefits? So do you recommend, or can you do individual elements?
Well, you can do individual elements. So when this was first set up, those 102 organizations that completed their assessments back in 2014, you had no choice. You had to complete an assessment from beginning to end. All 6 elements were included. But we completely reworked BPCLEtool in 2015-16, and so now you can conduct an assessment against just a single element of the framework. And so for organizations who've already been through this process and who want to go back and just have a look at their particular trouble spots, you can just conduct an assessment against element 1 or element 3 or elements 3 and 6 or whatever combination that you want.
Great. All right. Look, I don't think there's any more questions that are coming in, so we might draw things to a close. I'm just waiting to see if there's a last thing. But what I would say to people again is, if you do think of some questions, Donna's contact details are obviously available. I think you've made them available, so feel free to write a question through email or to call Donna. I mean, Donna does provide the help desk functionality as well for the BTOol, so I'm used to dealing with health services. But I'll just do a final check. No, I think that's all. So once again, as we said, the presentation we'll send the link to all the people attending, and we appreciate your participation today and listening. I found it very informative, and look, it's amazing the amount of data that's there. And I mean, we'll continue, as you said, there's the indicator data will be the next stage to look at that, and I think that's what the department will be doing, possibly some of that work. Or yes, so look, thank you very much. And hold on, I think we've just got another question. Sorry, before we sign off.
Look like a couple of questions there.
So a question is, with the changes in the assessment data between first time and second time, did you give any consideration to the fact that maybe different participants were completing the tool?
Absolutely, we did. Yes, you're right. Because the Likert scale responses, that is subjective. What seems very good to one person might not seem very good to another person. And that was why we wanted to make sure that we were certainly paired in terms of the disciplines, because we were aware that different disciplines experience the same learning environment very differently. So if you had nursing involved on one occasion and not involved in the other occasion, then you're not likely to be looking at similar responses. So that's why we only looked at paired assessments, where the disciplines were the same. Of course, the personnel were likely to have changed in that time, but that's why I said that the evidence of improvement, it doesn't go so much from the fact that something that was rated very lowly the first time was rated better the next time. It goes from the data which shows something did not exist the first time, but then the second time it did exist, because that is the only way you can show sort of objectively that things have improved. But that is a good point. Of course, when different people rate the same thing, they will rate it differently for sure.
Great.
But can I just add one other point to that, and that is to say that there's actually a bit of literature out there now about the value of the tacit knowledge of people who work within environments, and that if you're really serious about quality improvement, no matter what area you're working in, you actually have to talk to the people who work at the front line to find out what's going on. People will sometimes dismiss that and say, oh, that's not hard data. They call that sort of, soft evidence. It's not soft at all. The people who work at the front line, who actually have to put the rubber to the road there and make things work, those are the people who know better than anyone else whether arrangements are effective or not effective, how efficient they're able to be, whether they're able to achieve everything that they try to do, how frustrating or annoying it is. So getting the data from individuals is actually a really important piece of data and evidence for how well things are going in your clinical learning environment.
Great. Thank you very much, Donna. And we will be conducting the second in our series, or the webinar series for this year, probably in sort of late June. So probably focusing more on some of the learnings from using the meerkat tool, as you were talking about briefly at the end. But we'll certainly be including everyone in that. You'll get a message around that. So hopefully we'll see you again at the next webinar. And thank you again for your participation, and good morning.
Thanks very much. Bye-bye.